behalf of the Sri Lanka Society of Gastroenterology, let me warmly welcome you to this webinar, which is the September edition of a series of monthly webinars which are organized by our society. The topic we are going to discuss today is on acute liver failure in children and will be presented by Dr. Meranthi Fernando. Dr. Meranthi Fernando is currently a senior lecturer in pediatrics at the Department of Pediatrics, Faculty of Medicine, University of Kelaniya, and is an honorary consultant pediatrician with special interest in pediatric hepatology and liver transplantation at the Colombo North Teaching Hospital and Colombo North Center for Liver Diseases. She obtained her MBBS from the University of Kelaniya and soon after obtained her research and MD Pediatrics from the PGIM, University of Colombo. Later, she obtained her MRCPCH, UK. Her clinical research interest is in pediatric hepatology and liver transplantation in children. Having finished her local training, she proceeded to the UK for clinical fellowship in pediatric hepatology and liver transplantation at the Liver Unit, Birmingham Children's Hospital. She has authored 23 research papers in peer-reviewed journals and in addition has 26 abstracts to her credit. She has received many awards, which include Merit Awards for Scientific Publication from the National Research Council Sri Lanka in 2012 and 2014. Over to you, Dr. Meranthi.
Thank you very much, Dr. Sanjeeva, for that kind introduction. Can I check whether I'm audible clearly?
Yes, loud and clear.
Perfect. Right. Okay. At the outset, I would like to thank Sri Lanka Society of Gastroenterology for inviting me to talk in this month's webinar on acute liver failure in children. Thank you so much. So I will share my screen now. Can I check again whether you can see my screen?
Yes, we can see the screen nicely.
All right. So okay to go ahead. Right, okay. So, very good evening, ladies and gentlemen. So, I'll be talking on acute liver failure in children today. So, just to give you some idea, when we say children, yes, it encloses a wide range of age spectrum from a tiny baby, a neonate, to a well-grown older child or adolescent. So yes, I'll be talking on acute liver failure in this range of children, ranging from a neonate to an older child or to an adolescent. Obviously, there are changes in the way we manage hemodynamics and the way we suspect the underlying etiology and the way we treat. We'll see what are the differences when we go on, okay? Right. At the beginning, I would like to put some questions. We'll have a think about these things and we'll see how far we can go at the end of the talk. Firstly, we'll have a little think about the definition of acute liver failure and what are the primary diseases which would cause acute liver failure in children. And what would be the clinical features in children, what would be their presentation and what are the physical signs we would be checking on. And what's the role of investigations? What are our aims and are they really helpful? Finally, we'll talk about the management and outcomes. Firstly, let's concentrate on the definition of acute liver failure in children. I thought this is very important because when in our clinical practice, we see a child with liver disease. They would come with jaundice or they might come with abdominal pain or abdominal distension. When we perform liver functions, we know we can see some derangement. But we have to have a clear idea when would we label them as acute liver failure. The reason is it's very important to label them as acute liver failure because that would determine the management. Unless we recognize them having acute liver failure, we might not be seriously thinking about it or seriously managing the child. Because sometimes, though they have acute liver failure, in the initial period, they might look quite well. So we should not miss the window of opportunity to intervene early in view of management. So it's very important to know what's the definition in a child. Let's concentrate on this. This is the standard definition of acute liver failure in children. And this definition was used as entry criteria for pediatric acute liver failure study, which included 418 children with acute liver failure. Firstly, we would look at the squared area. If we get a child with liver disease, with whatever the complaints they would come, we would perform blood test. Without doing a clotting, we cannot say whether they are in liver failure or not. So any child with liver derangement, liver dysfunction, it's must to have a clotting. If we have clotting, then we can understand whether this child would come under the category of acute liver failure or not. If we have prothrombin time more than 15 seconds or INR more than 1.5 with clinical encephalopathy. If you can see there is clinical evidence of encephalopathy, and if you have coagulopathy meeting this criteria, you could say this child has got acute liver failure. What about in the absence of encephalopathy? Or sometimes it's not very straightforward to detect encephalopathy in young children, especially in infants. So in the absence of encephalopathy, or you are not certain whether the child is having encephalopathy, still you could diagnose acute liver failure if the prothrombin time is more than 20 seconds or INR is more than 2, irrespective of the fact whether there is encephalopathy or not. Okay, right. So if we have this lab abnormality, we can put the child under the category of acute liver failure, provided there is no evidence of chronic liver disease, no signs of chronicity. And there is evidence of acute liver injury, which we can get from the history, examination, and biochemistry. And the coagulopathy, which is unresponsive to vitamin K. If we get a child where the INR is 3.5, and if we administer IV vitamin K and repeat the clotting in 8 hours time, and you can see clotting has normalized. So in that occasion, we cannot tell that is acute liver failure. In acute liver failure, the coagulopathy will not be corrected by IV vitamin K. Then you must be thinking, why are we giving IV vitamin K in acute liver failure? We will come to that. So basically, this is the definition. You really need to have a clotting when you categorize a child with acute liver failure. And the other key message is, in a child, you can diagnose acute liver failure in the absence of encephalopathy. What about the timing? Is it 3 months, 4 months, 6 months? Usually, acute liver failure we define within 8 weeks. If the symptomatology or the course of the illness extends between 8 weeks to 12 weeks, then we call it subacute liver failure. Usually within 8 weeks, we see the outcome, which may be good or bad. Right. So this is to give you some context about what would happen in acute liver failure. When you look at this picture, this is nothing to do with acute liver failure. This is actually a cirrhotic liver. So this is a child who carried a liver, or maybe an adult who had a cirrhotic liver. You can see shrunken liver and nodular liver. In contrast to that, this is the liver appearance in acute liver failure. You could appreciate liver is swollen and hyperemic, and the color. If you do a section, this is the appearance. There are necrotic and hemorrhagic areas. And histology will show a lot of necrosis. The hallmark of acute liver failure is liver cell necrosis, which would cause acute severe hepatic loss or acute severe hepatocyte loss. So the hallmark is liver cell necrosis. This has a clinical implication actually. We will discuss in the management. Sometimes we use antifungals routinely as prophylaxis in children with acute liver failure. That is because they have liver cell necrosis, which would precipitate or put them at a higher risk of getting fungal infection. So liver cell necrosis is a key component of acute liver failure. Having talked about the definition and what would happen in the liver appearance, we will see what are the primary diseases which may present as acute liver failure. This would become clinically very important because if we see a child with liver dysfunction and then we diagnose liver failure, then we have to see what are the possible diseases. So these are the diseases we should be suspecting if you get a child with acute liver failure. Let's start with infections. Ranging from neonate to an older child, there are various organisms or microbiological agents who would cause acute liver failure. Mainly viruses. I would start from the top. Herpes simplex virus, very important. It's a common cause of acute liver failure in neonates. I have made in red to highlight the causes which are predominant in neonates. So HSV is a common cause for acute liver failure in neonates. And it's very important to consider HSV as a possibility of acute liver failure early. The reason is HSV-induced acute liver failure carries very high mortality. Very high mortality. Unfortunately, we can't perform liver transplantation when the child has viremia. So unless you commence the baby on IV acyclovir as early as possible, which would be life-saving, there is a high chance of death. It's always okay to start IV acyclovir if you have a suspicion, where if the suspicion goes off, you can always omit it. But the advantages are more in consideration it early. Enterovirus, it's again very important. I think we diagnose enterovirus a lot in Western countries, but not in our part of the world because we do not have the diagnostics. However, that does exist. Parvovirus, adenovirus, and traditional hepatitis viruses. Hepatitis B is a cause of neonatal acute liver failure. However, it has come down with the effective vaccination nowadays. And to mention a word about hepatitis E, that is a virus which would cause acute liver failure, especially in liver transplant patients following the transplant. If they eat uncooked or barbecue pork, sometimes there's a high risk of getting hepatitis E, especially in post-liver transplant patients. Dengue, Epstein-Barr viral infections, cytomegaloviral viral infections, we all know that could cause acute liver failure. What about COVID-19? There are cases which had been reported about COVID-19 and liver cell injury, but not overt acute liver failure. So we are yet to see the literature about COVID-19 and acute liver failure. Leptospirosis and other organisms, any bacteria, again, other organisms can cause acute liver failure, but these are the main organisms we have to consider. What about drug-induced liver injury? Again, a common etiology. We all know paracetamol or acetaminophen, a well-known cause of acute liver failure. Among the other drugs, anti-TB drugs, anti-leprosy drugs, and anti-seizure medications, and there are other sorts of drugs which could cause acute liver failure. I would like to mention a word about sodium valproate that has got an interesting relationship with the liver actually. Sodium valproate can cause acute liver failure as idiosyncratic effect. In addition to that, sodium valproate could precipitate acute liver failure in mitochondrial disease. That has got a clinical implication actually. If you have got a child with developmental delay who might well be having mitochondrial disease, which is undiagnosed, and they have hepatopathy as part of their illness, which might have not manifested yet. And if this child has got epilepsy, and if you decide to start on sodium valproate in this child might get acute liver failure as a result of sodium valproate. The risk is higher compared to general population. So the main message is, if you have any doubt about mitochondrial disease, please do not consider sodium valproate as an anti-seizure medication. Apart from that, sodium valproate is known to precipitate Ray's syndrome in addition to aspirin. Ray's syndrome is a syndrome where you get coagulopathy, hypoglycemia, and encephalopathy, and acute liver failure, which is a bit less common nowadays. However, it could precipitate. What about metabolic liver disease? This is again an interesting group of disorders, which we increasingly identify in children nowadays with the availability of advanced diagnostics and genetics. Wilson disease, it would come under metabolic liver diseases, however, quite common. in older children and adolescents. It exhibits a various spectrum of liver presentations. Wilson disease can present with acute liver failure, acute on chronic liver failure, decompensated chronic liver disease, just hepatitis, or it could just present as incidental detection of transaminitis. So yes, it would come as acute liver failure. Tyrosinemia type 1 and galactosemia. Galactosemia is very important. The natural history of galactosemia is usually they would present around 7 to 10 days of life. A term baby who is born normally discharged home presents on day 7 or day 10 with an intracranial hemorrhage and coagulopathy. And when you check the bloods, the child is in acute liver failure. So we have to suspect galactosemia. There may be consanguinity in the history. The first step to do if you suspect galactosemia is to stop breastfeeding. Stop breastfeeding and suspect E. coli sepsis. They are more likely to get E. coli sepsis as well. Fatty acid oxidation defects, urea cycle disorders may present as acute liver failure. Hereditary fructose intolerance and PFIC type 2 or BACP deficiency. There are cases reported as acute liver failure. Mitochondrial disease, again a well-known cause, present as acute liver failure, Ray's syndrome, and Niemann-Pick type C. So those are the common metabolic disorders among acute liver failure, and you can see some of them would occur or present in neonatal period, which are highlighted in red. Let's look at the other etiologies. Autoimmune hepatitis, a known cause for acute liver failure. Gestational alloimmune liver disease, previously known as neonatal hemochromatosis. The new terminology is gestational alloimmune liver disease or GALD. It's very important to suspect GALD. The reason is GALD has got a kind of a worse prognosis or poor prognosis. Yes, we have some therapeutic options if you suspect GALD, like exchange transfusion or IVIG. However, the anticipated outcomes are not really good. So you have to escalate them early for liver transplantation. So transplant-free survival is quite less in GALD. And it's very important to diagnose GALD in other means, because if you diagnose GALD in this baby, there are special precautions to be taken in the mother in the next pregnancy to avoid GALD, because that's an alloimmune process where the damage to the liver occurs in utero. So there are certain measures which we can take as preventive measures in the next pregnancy during the antenatal period. So it's very important to look for these causes. HLH, hemophagocytic lymphohistiocytosis, may present as acute liver failure. Recurrent acute liver failure syndrome, again a unique entity which came into existence in the last decade. And you can see this publication, and there are several publications which had come through. There were children who came with the picture of acute liver failure recurrently. So then the teams in specialized units, they started investigating in view of genetics. Can we find a name for this disease? They come with acute liver failure. When we give supportive care, they improve. So when they looked at the genetics, they were able to isolate some mutations, and one is NBAS mutation. And there's another mutation called LAS mutation, which are associated with recurrent acute liver failure syndrome. And usually they do not need liver transplant if you suspect recurrent acute liver failure syndrome. And usually they can be managed conservatively with lipid infusions. And they have found out they are beneficial. Lipid infusions can be used in the management. And you can prevent them getting transplant. The challenge would be if they come with the first episode. Though it's recurrent acute liver failure syndrome, they would come with the first episode and they have to survive the first episode. So it's important to consider. What about malignancy? Yes, malignancy, again, hepatoblastomas occupying the entire liver can cause acute liver failure. And apart from that, leukemia causing hepatitis and acute liver failure is again known. Hemangioma or AV malformations, can they cause acute liver failure, and how can they cause acute liver failure? I have come across few cases where young children had hemangiomas and AV malformations occupying the entire liver, and they did not have any liver mass to sustain liver synthetic functions. And obviously they went into acute liver failure in early neonatal period, requiring liver transplant. So it's very important to perform ultrasound scan and then subsequent imaging to find out these etiologies. And then indeterminate and seronegative hepatitis. That is again a difficult entity. If you have performed almost all the investigations and you haven't found any cause with your investigations, you have to think about indeterminate to seronegative hepatitis. And it's mentioned in the literature up to 40 to 50% of the cases of pediatric acute liver failure are unfortunately indeterminate or seronegative. Yeah, it's true that we put this name when we don't have a clear name. However, people have identified a specific prognostic implication in regards to this seronegative hepatitis. If you have a child with seronegative hepatitis, the recommendation is to escalate for liver transplantation early. The reason is the anticipated prognosis is not quite good. One reason may be self-explanatory because you don't have an etiology, so you can't treat it. So that may be one of the reasons. And in other words, this group of disorders have resulted in poor outcomes when they have done prospective studies. So seronegative hepatitis anticipate problems and escalate for liver transplantation early. Lastly, ischemia can damage the liver and it can cause acute liver failure, or else acute liver failure may occur as part of multi-organ dysfunction. Having gone through the possible diseases which can cause acute liver failure in children, this is to give you some context actually. This is again from the pediatric acute liver failure study group or study registry, where they have studied 418 children who had acute liver failure. And if you could appreciate, though it's small in font, the largest group had been paracetamol and indeterminate, paracetamol overdose and indeterminate causes. And if you look at the rest of the causes, you can see infections, the ones we have discussed already. And the next interesting group would be the metabolic liver disease. And you could see the spectrum of metabolic disorders which had presented with acute liver failure. Let's now look at the clinical features. So far, we have gone through the definition of acute liver failure. What are the primary diseases which would present as acute liver failure? And now we will look at what are the clinical features, what are the important things in the history we have to ask the child or the parents. They will have a history of jaundice and CNS manifestations like drowsiness, behavioral changes, abdominal distension, bleeding tendency. Obviously, these are related to the liver dysfunction. Apart from that, shall we have a look at what are the things we can ask in view of etiology? Consanguinity important in view of metabolic liver disease and previous acute liver failure episodes, especially in recurrent acute liver failure syndrome, sibling or family deaths, travel history, cholestasis in pregnancy, important, especially in progressive familial intrahepatic cholestasis, where the mother would get cholestasis in infants, cholestasis in pregnancy, where the baby was in utero, which is giving rise to liver dysfunction in the mother. And transfusion of blood products might indicate hepatitis B infection. Drug history, very important, especially if you don't have a reason. You have to dig into the drug history. Sometimes they might not tell you at the first encounter that the child had been taking some medications. So you might have to dig into that history repeatedly. And development is important, especially in the context of the multisystemic disorders like Niemann type C, mitochondrial disorders. It's quite important. What are the things we would look at in the examination? Sensorium, GCA is important in view of encephalopathy, the level of jaundice, and the jaundice may be partly due to liver dysfunction and sometimes may be due to hemolysis. especially in autoimmune liver disease and Wilson disease. Looking at cave rings, if it is visible for naked eye, cataracts in galactosemia, microcephaly, again in galactosemia, tallow, Wilson disease and autoimmune liver disease, you can get anemia, bruises which would indicate the level of coagulopathy, skin rashes, especially vesicular rash in herpes infection, fetal hepaticus, which would indicate the liver damage, again flapping tremors or asterixis, hepatomegaly, splenomegaly will give you some clues, and ascites. Ascites could occur in the context of acute liver failure. If there is a significant synthetic dysfunction and cell damage, you can get ascites. And at the same time, it's important to look at the signs of chronicity, because it's very important to identify whether this is truly acute liver failure or is this acute on chronic liver failure, because sometimes management strategies and other things are different. This is to indicate the stages of encephalopathy, stage 1, stage 2, stage 3 and 4. So sometimes it's very difficult to get these signs in young children. However, we have to try our maximum to grade them or stage them and then implement our management. Because the CNS manifestations are very important in acute liver failure, especially cerebral edema, which is the killer. And encephalopathy would progress into edema. This is to give you some idea. Acute liver failure, though it involves liver, it has got a cascade of things happening in other organs, which we have to take into consideration in our management. Because it's not going to be simple in next few days. If you have a child with acute liver failure, it would affect other organs as I have listed here in various forms. So we have to be mindful that we are not concentrating only on the liver, we are looking at the entire picture and we are looking after the other organs as well. And especially decision making in anticipation. You look for the problems and you anticipate problems and then implement a management plan. No point if you get established hepatorenal syndrome or renal failure to get renoprotective measures. You should not be waiting till then. You should have some idea to avoid pre-renal causes for renal failure and other possible causes in a child with acute liver failure, because you know they can get hepatorenal syndrome. So likewise, you have to look after the other organs as well, knowing there will be a cascade of events happening in other organs. All right, so now we have come going through few aspects of acute liver failure. One is looking at the definition, clinical features, and then we will see how would the investigations help us. What are the investigations and what are our goals when we perform investigations in a child with acute liver failure? These are goals I could think of. I want to know the liver status of the child. How bad is this acute liver failure? How bad is the clotting? How bad is ammonia? So the liver status is important. And what about the etiology? Because if I know the etiology, I can implement some specific management strategies, or else sometimes we can escalate it early for liver transplantation. And complications. Again, we would perform investigations to look for complications. And lastly, but importantly, transplant workup. The reason to mention transplant workup here is you might not have much time to play with a child with acute liver failure. So if you think this child is not going in the right direction, we might have to escalate into liver transplant. We should not wait. We should simultaneously start the liver transplant workup. Because that's very important. No harm you starting liver transplant workup and having a chat with the liver transplant unit. The reason is because you can always wait without doing liver transplant. However, if you are late without having your workup ready, you can't offer the best care to the child. So it's very important you consider liver transplant early and perform liver transplant workup and keep everything ready. If you happen to do it, you will go ahead. Otherwise, we are very happy that we have avoided liver transplant. So these are the main goals we would have in our mind when we have a child with acute liver failure and when we plan our investigations. Let's look at briefly about different parameters we would do. So we would obviously perform transaminases. How are they going to be useful for us? So transaminases, usually the transaminases are significantly high in viral hepatitis or in autoimmune hepatitis. However, or else in paracetamol overdose, obviously, the drug-induced liver disease. In other etiologies like metabolic liver disease and Wilson disease, sometimes the transaminases may be near normal. What I'm trying to say is the level of transaminitis might not indicate how sick the child is. So yes, it's important to look at the trends of transaminases. However, do not get reassured with the level of transaminitis. Sometimes child might have significant coagulopathy, might not have significant transaminitis. So it's very important. Gamma GT and alkaline phosphatase, not very specific, but sometimes with different etiologies, it might be useful. Bilirubin, very important. Bilirubin is very important because cholestasis will be indicated by bilirubin. And if your child is persistently jaundiced and the jaundice is getting worse and the bilirubin level is rising, then it's very important you would consider other therapeutic modalities like liver transplantation early because it seems that you are not winning with your management. Albumin again will indicate liver synthetic function. Low albumin would indicate significant liver damage. So it's very important to perform albumin. Clotting, I would say the most important investigation. You can't diagnose acute liver failure without having clotting. You can't monitor a child with acute liver failure without having clotting. You can't list a child for liver transplantation without having clotting. So it's very important. If you ask me what is the best or most important investigation, it would be clotting. So it's very important you will perform a clotting and you will be guided by the course of the illness or the natural history of the disease by clotting. And the other thing would be fibrinogen and APTT, those are also important. And rotem again is very important, especially when you are rationalizing your blood products in acute liver failure. The novel technique or the most recent management is not to correct your PT. You are not going to correct your numbers. You are going to guide yourself for blood transfusions or blood product transfusions by rotem. So now in this era, we would never correct a prothrombin time or INR. If the INR is more than 4, we would not give a FFP. That is not the management. You will do prothrombin time just to get an idea whether the acute liver failure is progressing or improving. However, you will not decide your blood transfusions or blood product transfusions based on prothrombin time. You have to get guided by the rotem and minimize transfusion of blood products. We will talk about that in management as well. So it's very important you look at the clotting profile. And ammonia, obviously, yes, it will cause hepatic encephalopathy and the liver excretory function is impaired. So ammonia is very important. And I have indicated alpha-fetoprotein here. I have a reason for that. I would really like to have alpha-fetoprotein. One reason is it would give some idea about the etiology. Like tyrosinemia, gestational alloimmune liver disease, they would have very high alpha-fetoprotein. Apart from that, alpha-fetoprotein would indicate liver recovery sometimes. If I have a child with paracetamol overdose whose clotting is improving and transaminases are coming down, however, alpha-fetoprotein is rising, I would be happy. I would not be unhappy. I would be happy because child is clinically improving, transaminases are coming down, clotting is improving. So alpha-fetoprotein would rise, which would indicate liver regeneration. So that's very useful in the clinical setup. As next step, we need some more investigations just to get an idea about the end organ damage and what is happening with the rest of the body. So blood sugar, it's very important because acute liver failure, if you have low blood sugar, we know we are not doing very well. So it's very important to maintain normoglycemia, and prognostically also blood sugar is very important. So you have to check blood sugar very regularly. Blood gas, bicarbonate, base excess, and lactate. Lactate is very, very important again when you monitor a child with acute liver failure. Renal functions and electrolytes. A word about electrolytes. Phosphate is also very important in addition to the other electrolytes. The reason is usually in acute liver failure towards recovery phase, they would classically get low phosphate. And if I see low phosphate in a clinically improving child, I would be happy because that would indicate child is going towards recovery. And of course, we have to supplement phosphate and facilitate that recovery. So it's very important to look at phosphate. EEG and CT brain may be required, especially EEG to monitor cerebral function and the electrical activity in view of hepatic encephalopathy. And other investigations to look for septic screen as well as chest X-ray if you have any doubt about the lungs. And again, obviously DT is needed in case of a bleeding. You have to be ready with blood products. In view of sepsis, acute liver failure, we routinely use prophylactic antimicrobials, antibiotics, antifungals, and sometimes antivirals. And on the other hand, as I have mentioned earlier, there will be liver necrosis, liver cell necrosis in acute liver failure. So there's a secondary likelihood of getting infections as well, especially fungal infections in the context of acute liver failure. So it's very important you look at the septic screen, you monitor CRP, and you cover the child with a broad spectrum antimicrobial. Now let's look at why it is important to look for the cause. Look for the cause of acute liver failure. Yeah, it's very important to know the cause due to many reasons actually, but if we look at the main reasons, it would help us to implement disease-specific management. If you identify Wilson disease, you could start copper chelators early. And if you identify autoimmune liver disease, then again you can start steroids early, which may prevent the child requiring liver transplant. So it's very important on day one itself, we take a very speedy attempt to diagnose what this acute liver failure is due to, because it's very important to treat the specific disease, which may prevent liver transplant, which is good. And it's helpful to predict the prognosis as well. As I mentioned earlier, if you have a child with paracetamol overdose causing acute liver failure, we know we have N-acetylcysteine, and usually the liver would regenerate. And they might really require liver transplant, but usually they would recover. So we are quite content. However, in Wilson disease, if they have encephalopathy with Wilson disease, usually they would not escape a liver transplant. So we have some idea about the anticipated prognosis by knowing the etiology. And mitochondria. If we have a child we suspect mitochondrial disease, we would not consider liver transplant in that child due to multisystemic nature. So we would manage conservatively. So that would guide our management how far we are going to escalate this. And then early escalation for liver transplantation, again, as I have mentioned earlier, seronegative hepatitis. We know if we have a child with seronegative hepatitis, we are not going to escape transplant mostly. So we would start our workup early and have a chat with the transplant unit and decide on liver transplantation. And future pregnancies, it has got implications on future pregnancies as well. If the disease is gestational alloimmune liver disease, it's very important. Even if we can't save this child, it's very important you make a diagnosis, because in subsequent pregnancies, there are special regimens we would implement to that particular mother in antenatal period to prevent liver damage due to gestational alloimmune liver disease. So it's very important that we make an attempt to diagnose this. And metabolic liver disease, again, we can do genetic counseling and we can plan things ahead from day one. in next pregnancy. This is one example if we know the etiology where it will help us to guide through our management. So this is modified King score or new Wilson index, King's-Wilson index. This score helps us to identify a child who would need liver transplant when the child is having acute presentation or acute liver failure. So we put all these parameters, and if the score is more than 11, we can confidently say we would like to this child for liver transplant urgently. The challenge comes if you diagnose Wilson disease, we know it's a disease which can be treatable. So then you have a diagnostic dilemma. Should I be using my copper chelators and should I be waiting, or should I escalate this child for liver transplantation? Because we know some children, though they present with acute presentations in Wilson disease, we can rescue them without going ahead with liver transplantation. So sometimes it's a difficult decision whether to wait with chelation or to go ahead with liver transplant. So this is very useful for you to justify your decision and to be confident in what you do. If the score is more than 11, you know there's a high likelihood of this child dying without transplant. So we would escalate. We would not wait with copper chelators. And the other thing is, one experience I have is usually in Wilson disease, if they have encephalopathy and acute presentation, and they are very unlikely to be rescued with chelation, but it may occur, but usually it's less likely. Okay. So now we have looked at the general investigation, how are they going to be helpful, and why it is important looking for underlying etiology. So this is to give some insight about specific investigations and the diseases when we do our investigations. If we suspect infections, we have to do respective infective screening. Paracetamol or other drugs, we have to do drug levels. Autoimmune liver disease, again immunoglobulin, autoantibodies and liver biopsy. Autoimmune liver disease, it's a must to have liver biopsy if you have expertise and the infrastructure to do in the setup of acute liver failure. Wilson disease, ceruloplasmin, serum copper, eye assessment, urinary copper, liver biopsy, and genetics. And I would like to mention a word about genetics. In pediatric hepatology and pediatric liver diseases, most of the diseases other than biliary atresia have got a genetic background, and we have identified genetic mutations. So we really advocate getting a genetic diagnosis for these disorders. You might not get a genetic diagnosis overnight, that's okay. Still, it's very important. You take a blood sample, EDTA sample, and you send it for genetics. If the situation is unfortunate, if this child dies, still if you get the results, that would help for future pregnancies and genetic counseling and other things. And you have made a diagnosis which would give you some insight for management of other children in the future. So always as pediatricians, we should make an attempt to diagnose these conditions genetically. And it's very important before giving blood transfusions or blood products, we take an EDTA sample for genetics where we can send it later. And other metabolic disorders, it's important to do ammonia. Sometimes ammonia would be out of proportionately high in metabolic liver disease, especially in urea cycle disorders. And amino acids, organic acids, and all the other metabolic screening is important. Gestational alloimmune liver disease, yes, ferritin is important. It will be high. Alpha-fetoprotein will be high. Lip biopsy of the lip to get some minor salivary glands, and then we can demonstrate the deposition of the iron in gestational alloimmune liver disease. And T2 MRI of the liver and other abdominal organs where you have to demonstrate actually the extrahepatic deposition of the iron rather than the liver. The other organs like pancreas and all, we have to demonstrate that there is iron deposition in other organs other than the liver. So T2 MRI of the abdomen would be helpful. Mitochondrial disease, it's important to do lactate and MR spectroscopy, muscle biopsy, and genetics, depending on the situation. There is a category of acute liver failure where you get indeterminate hepatitis with aplastic anemia. Or sometimes in HLH also, bone marrow biopsy is useful. So in these two occasions, bone marrow biopsy is indicated. Imaging. What's the role of imaging? It is useful as a baseline looking at the liver echogenicity, signs of chronicity, just to differentiate whether this is true acute liver failure, ascites, looking for etiologies like vascular lesions and malignancy, and to guide the liver biopsy especially, because nowadays we do perform liver biopsy with the help of the interventional radiologist, giving the best care to the child, best possible opportunity for the child to undergo liver biopsy with minimal complications. So ultrasound scan would guide the interventional radiologist to do the liver biopsy, especially in a difficult setup in acute liver failure. And this may be part of the transplant workup. An MRI is useful in gestational alloimmune liver disease. To mention about liver biopsy, though I say liver biopsy to be performed in the setup of acute liver failure, it's quite challenging. However, it's very useful in autoimmune hepatitis, malignancy, and hemophagocytic lymphohistiocytosis, where you really need a tissue diagnosis. It's challenging in the setup of acute liver failure due to multiple factors like bleeding, ascites, and sepsis. Because there is coagulopathy, you might have to correct coagulopathy under ROTEM guidance. And there may be ascites, which would preclude you doing a percutaneous biopsy. And there may be a risk of sepsis when you do procedures. So it's challenging. And we know after going through the stroke so far, we would guide our blood transfusions and blood product transfusions with ROTEM. And it should always be a IR guided biopsy, which may be percutaneous, or if there are contraindications like ascites or bleeding tendency with low platelets, we might go for transtubular biopsy with the help of interventional radiologist. Finally, we would discuss management, which is the very important part actually. Firstly, I would like to emphasize when it comes to management, labeling a child with acute liver failure as acute liver failure is very important. Because we have a child who looks quite well, talks to us in the morning board round, and mother says child is reasonably okay. So we might doubt ourselves, is this acute liver failure? Child looks well. No, if the parameters indicate if this goes by the definition, we would label the child as acute liver failure. Otherwise, that seriousness would not come into our mind to implement the specific management, which would be dangerous because we might try to do everything when the child gets worse, which is not the right thing. So we have to label a child with liver dysfunction as acute liver failure if the child meets the criteria in the definition. That's very important. And then we'll concentrate on this. So this pediatric acute liver failure study group also had mentioned it's very important to liaise with the liver transplant unit early, just to have a chat with them, maybe to get some guidance for management, as well as to notify them that there's a child like this, because child might need liver transplant sooner rather than later. So it's very important. And what about the other aspects of the management? Child should be managed in ICU setup or HDU setup. IV access is very important, because if you think this is a child where IV access is very difficult, it's very good to get good IV access with a central line early rather than later when the coagulopathy becomes worse. So it's very important to plan these things. Fluid restriction is recommended provided your blood pressure is normal, 75 to 80%, which is very beneficial to avoid cerebral edema, which is the killer in acute liver failure. And you will use IV fluids, 0.9 saline and dextrose ranging from 5% onwards, depending on your blood sugars. And you should make sure that all the drug volumes are calculated for this fluid restriction, and they are included. Antimicrobials, we normally start them on antibiotics, broad spectrum, antifungals. We start them on fluconazole, which is very safe in acute liver failure, and we start them on antivirals if that is indicated. Parenteral vitamin K. I have said at the beginning, acute liver failure, the coagulopathy, would not be corrected with vitamin K. So why do we give parenteral vitamin K? It is to facilitate the recovery. When the child is trying to recover, we should give this cofactor and help the child in recovery. We know that acute liver failure is not going to be cured by vitamin K, but the body will try to recover, the liver will try to regenerate, so we are trying to give some help. And actually, we can differentiate by giving it whether this is true acute liver failure or not. Ursodeoxycholic acid is important when there is cholestasis. Maintaining sugar and electrolytes very important. If there is edema or ascites with hyperalbuminemia, albumin infusions, we use 20% albumin, normally over 4 hours with a midday furosemide. And spironolactone is very useful as a diuretic. We avoid furosemide unless it is coupled with albumin infusion because it can cause hyponatremia. So the preferred diuretic to start with is spironolactone. Acid prophylaxis is very important because this child has got a tendency to bleed anyway. So it's very important we give some GI protection or GI prophylaxis with omeprazole and sucralfate. Lactulose to keep the bowel clean to avoid hypomoniemia. To the same matter, rifaximin and neomycin. And rational use of blood products. I'll give you 2 clinical examples. We had one child who had an acute presentation, acute liver failure, and who had an INR of 6. And we did not give any blood products, and child did not have any bleeding. So that is one example. We should not rush to give blood products based on INR. They don't normally bleed. They don't normally bleed. It's our anxiety which makes us to give blood products, which has got actually bad consequences. It might cause cerebral edema. It might have adverse outcomes if the child undergoes liver transplantation, and it might cause anaphylaxis. It might increase the risk of sepsis. So we would always get guided by ROTEM and the clinical evidence of any bleeding rather than just trying to correct prothrombin time or INR. So there is no real cutoff for INR. You go by the clinical judgment. Even INR of 6, 7, 8 in a stable child would not require FFP transfusion. And sometimes they would require cryo rather than FFP due to fibrinogen deficiency. That is why it's very important we do a ROTA. Nutrition is important. Protein 1 to 2 grams per day and special precautions in metabolic liver disease. Pain relief. We have to avoid sedation because it can worsen encephalopathy unless it's really needed. Neuroprotective measures, very important. Renal replacement therapy, because we know acute liver failure can cause hepatorenal syndrome and there are other reasons where you can have renal impairment. So as a bridge to recovery, we may consider renal replacement therapy. There are no studies to say that LOLA is effective, though it's used in other setups. So we do not use that in children. So that's about general management of a child with acute liver failure without knowing even the etiology. So what about the specific management, especially if you know the cause? If it is paracetamol overdose, very straightforward. All the pediatricians, we know how to manage a paracetamol overdose with N-acetylcysteine as per the BNF regimen. One addition to that, normally the advice is to consider NAC and continue to give NAC at a dose of 100 to 150 milligrams per kg per day, even though you finish initial 48 hours or so, if the prothrombin time is prolonged. And how would we make a decision to stop NAC? That's the difficult part sometimes. You will get guided by the prothrombin time, not by the transaminases. If the prothrombin time is less than 16 seconds, then you can safely stop NAC. Till then, you would continue NAC at this dose. So transaminases would not guide duration of NAC, but PT would. This is just to give you some insight from evidence. So this study had looked at the role of N-acetylcysteine in the treatment of acute non-acetaminophen, non-alcoholic, non-viral hepatitis. So what were the findings? So it had concluded NAC does not improve overall survival or the rate of infection in patients with acute non-paracetamol poisoning liver failure. In fact, it may delay the liver transplantation. This is one reason why liver transplant centers, they don't advocate this using of NAC because it might delay the escalation into liver transplantation. This is another study which had given some idea about efficacy and safety of NAC. We look at what they have said. they have said something different. They have said NAC was shown to significantly improve transplant-free survival in adult patients. But there are no significant or statistically important data in children. So for the time being, no evidence to say NAC is useful in non-paracetamol overdose-related acute liver failure. However, it may be individual clinical decision. This is another study. Again, they have said NAC had been beneficial. So there are conflicting data which had come through. More insight about specific management. If we have these specific etiologies, we can implement these specific management strategies, which we already know. So it's very important we look through the course. Finally, it's very important to monitor these children carefully. So how frequently and what should we monitor? Vital parameters, we should monitor 1 hourly. Urine output, our target is to maintain more than 0.5 milliliters per kg per hour. Neuro observations, very important. Temperature, 6 hourly, because sometimes hypothermia and maintaining normothermia is important. In vivo facilities, measuring weight daily is important, and cerebral function monitoring. What about blood investigations? We should do blood sugar, clotting, and a blood gas 8 hourly, and other liver bloods and full blood count at least twice a day. I wanted to emphasize CNS manifestations in acute liver failure because that is the killer in acute liver failure, not coagulopathy, though we think it is the killer. So we know we don't need encephalopathy to diagnose acute liver failure. So there may be a child who doesn't have encephalopathy at the beginning. And we know these are the grades we have to look if we suspect encephalopathy. And adding a little bit into that, you will need ammonia if that is available, and baseline EEG and cerebral function monitoring. CT brain is useful to identify cerebral edema. And all these neuroprotective measures are very important because our main focus about the killer, which is cerebral edema, should be very, very thorough. Because we always consider coagulopathy, bleeding, and we are very scared about bleeding, but it's doubtful whether we put enough attention into these neurological manifestations of acute liver failure. So I wanted to highlight these all neuroprotective measures and early escalation to liver transplant in view of neurological manifestations. Because if the child goes into significant encephalopathy, child might become untransplantable. Child might become unsuitable candidate for liver transplant. So it's quite sad. That's why we need to detect this early. And severe cerebral edema again will preclude liver transplant, unfortunately. A word about plasma exchange. Is there a place for plasma exchange in acute liver failure? Yes, especially where you don't have liver transplant in-house or in your country. In other countries, at the moment we have a program, so we can use plasma exchange as a bridge for liver transplantation, or if you don't have facility to do liver transplantation. So we have to get our intensivist as well as transfusion medicine consultants when we plan plasma exchange. What's the evidence? Yeah. So this is again some data which is telling therapeutic plasma exchange can act as a bridge to liver transplant or bridge to recovery, especially in self-limiting illnesses such as viral hepatitis. And this article has again emphasized plasma exchange for more than 6 times probably offers little benefit with regard to patient survival if liver transplantation is not performed promptly. So basically, in conclusion, what we understand is plasma exchange is useful. It sometimes serves as a bridge to transplantation or might facilitate recovery. However, if you have the facilities to do liver transplantation, we should not waste our time with plasma exchange. We should escalate for liver transplantation. That is what this evidence concludes. Finally, these are the warning signs if you have a child with acute liver failure. If you have a child whose liver functions, coagulopathy is getting worsened, and the transaminases are coming down, but the clotting is getting prolonged, so we would be unhappy. And persistent or worsening of jaundice, cholestasis, again a bad marker. Liver size is coming down, that means it's getting necrosed. Worsening cerebral edema, or depending on the underlying cause, especially seronegative hepatitis, we have to consider them as warning signs. A word about liver transplantation for acute liver failure. It's very important we consider liver transplantation as a treatment option. Early planning and discussion with the liver transplant unit is crucial. It may be cadaveric or live-related, or in developed countries, it may be even auxiliary liver transplant. And there are several contraindications like underlying cause. If it is Niemann-Pick type C or mitochondrial, we may not consider liver transplant. And severe cerebral damage and sepsis may preclude going ahead with the liver transplant. So having gone through the definition, etiology, clinical features, and management, these are the three primary outcomes we can anticipate in a child with acute liver failure. In developing countries, a significant proportion of children would die with acute liver failure. However, some would survive with native liver, they would recover and regenerate, and some would survive with transplanted liver. I would anticipate with better understanding, we would offer better care for our children, where we would shift the curve towards surviving with native liver and survive with transplanted liver. So that makes me to summarize what I have talked today. I wanted to emphasize actually three main facts. It's very important to identify acute liver failure in the context of liver dysfunction. So we have to stick to the definition. And meticulous management, and very important to look for the cause. And consider liver transplantation early in the disease course. These are main key messages I want you to take home. Thank you very much for your patient listening, and thank you for joining today.
Thank you, Dr. Meranti, for that very informative and comprehensive lecture on this topic, which is very important for us as gastroenterologists, since although most of us have not done any pediatrics after our medical student days, we get often referrals for these patients. If you have time, we have few questions.
Sure.
That be okay? Yeah.
Yeah, that should be fine.
Yeah. So one question is on use of sodium benzoate in acute hepatic encephalopathy. Do you have any experience?
Yeah, thank you for that question. You can hear me clearly now.
Yeah, we can hear you.
Yeah, yes, there is a place to answer to that question. If there is significant hyperammonemia, especially in the context of metabolic liver disease, you would say urea cycle disorders, they would have very high ammonia, sometimes out of proportion to hepatic encephalopathy compared to any other etiology. So in those scenarios, there is a place for sodium benzoate, arginine infusions, and other measures which would make the ammonia coming down. And plain and simple hepatic encephalopathy, in the absence of metabolic liver disease, still there is a place. Yes.
And what's your opinion on copper chelation during acute liver failure? Some are reluctant to use it there because they are afraid that it might worsen the acute liver failure. In our setting where we don't have much access to liver transplantation, what's your opinion?
I would say that is very safe, because what is not safe is sometimes steroids. Because usually in acute liver failure, if it is due to autoimmune liver disease, still we are reluctant to start steroids. That child is having secondary sepsis. But in contrast to that, in Wilson disease, copper chelation is very safe. The only worry is worsening of neurological features, but it would never worsen the coagulopathy or acute liver failure. Being a treatable disease, it's very important we would start copper chelation early. So I would not have any reservations for that. I would strongly recommend to start copper chelation.
And what would you recommend as pain relief and for temperature control in acute liver failure?
Yeah, pain relief, we can use paracetamol. Usually we go for a slightly lower dose, like 10 milligrams per kg per dose instead of 15 milligrams per kg per dose, which we use normally. And if the child is very distressed and restless, if we really have to use sedation, we have to avoid benzodiazepines. What is relatively safe is fentanyl rather than midazolam and other medications. Fentanyl is relatively safe. And if you feel it's very difficult to manage without sedation, then we may go ahead with intubation and neuroprotective ventilation and then sedation. Yeah, because the body is cerebral edema and worsening encephalopathy with sedation. It should be used, but yeah, in a reserved approach.
And can you advise on us on any place that we can get genetics tests in Sri Lanka? With regard to this?
Yes, targeted genetic mutational analysis is offered by chemical pathology lab in Lady Ridgeway Hospital for certain diseases. You have to coordinate with Dr. Iresha Jasinger, madam. So it's offered free of charge. So it's very useful. One reservation is it offers targeted mutation analysis, so kind of a small pool of genetic mutations as far as I understand. What is now recommended in the current era is whole exome sequencing. So nowadays we don't look at targeted mutations because sometimes rare genetic disorders you can't really say, look for this particular mutation. If I suspect Wilson disease, I can say, please look at ATP7B gene. But if I have a wide spectrum of differential diagnosis, sometimes it's difficult for me to say, look at this gene. So in that case, I would require whole exome sequencing. So at the moment in Sri Lanka, there is no place where you can get whole exome sequencing for free of charge. However, I have had some partnership with a laboratory in Colombo. I would not mention the name in view of conflicts of interest. So if you want to get it done, you can have a chat with me because they do offer it for a concessionary price for our unit. So I can arrange whole exome sequencing through our unit for a reasonable price. Yeah.
And what about using anticoagulation in patients with acute liver failure when they have a portal vein thrombosis and hepatic vein thrombosis? Would you go ahead with anticoagulation?
It's kind of a balanced decision. It's not really common in pediatric practice, I would say. It's not, maybe in adults with the other comorbidities and other things. It's quite uncommon in children, I would say. If it happens, again, we have to balance the risk and benefit we can use, because the liver failure would cause decrease in clotting factors as well as anti-clotting factors. So we have to balance it with the ROTEM and use. It's not absolute contraindication. However, it's very uncommon, but we can use depending on circumstances.
And your view on using NAC in Ray's syndrome?
Yes, again, it is not proven. However, I would not really discourage using it because the mechanism of action, if you think about NAC, is increasing glutathione and then it helps the liver for recovery. And especially if we don't have liver transplant, which is happening soon, sometimes you have a patient, you don't have a donor to transplant. So in that kind of a setup, if you are desperate and if you have a child with Ray's syndrome, I would support, though there is no evidence. Evidence might come in the future, but sometimes we are desperate. We can't really get the evidence from a Western country where they have in-house liver transplantation. So there is no contraindication. However, we have to be mindful NAC will have adverse effects like anaphylaxis. But if you are giving NAC, that has to be intravenous. There is no place for oral NAC. That I would like to say. And in Ray's syndrome, it's always important to look for the precipitant like aspirin, varicella infection, or sodium valproate and get rid of the precipitant.
And for cerebral edema, would you use 3% saline over mannitol? Or?
Yes. I would say 3% saline because the control of the intracranial pressure is quite smooth with 3% saline, and there is evidence. And I'm sure the intensivists would agree with me. We hardly use mannitol in children. Yeah, 3% saline is better. Yeah, in mannitol you get a lot of variations in the spectrum. Yeah.
What is the target sodium that you would like to achieve?
140 to 145.
Okay, I think those are all the questions that we have got. So on behalf of the Sri Lanka Society of Gastroenterology, I would like to thank you for taking this opportunity and presenting this excellent lecture to us, which will, I'm sure, help all of us. So thank you, Dr. Miranti.
Thank you so much for inviting me, and thank you for everybody who joined today. Have a pleasant evening.
Thank you.